Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Trends in Health-Related Quality of Life Following a Diagnosis of Ductal Carcinoma in Situ by Vicky Hart et al. My name is Ann Partridge, and I am a medical oncologist at the Dana-Farber Cancer Institute in Boston, Massachusetts. My oncology specialty is breast cancer. Ductal carcinoma in situ, or DCIS, is diagnosed in approximately 50,000 women per year in the United States alone, with the majority of women diagnosed through screening mammography. Guideline concordant care dictates that women with DCIS are treated from a local therapy standpoint with lumpectomy followed by radiation, or mastectomy. Subsequent adjuvant hormonal therapy with either tamoxifen or an aromatase inhibitor, if a woman is postmenopausal, can also be considered for further reduction of risk of local recurrence and new primary breast cancer. However, interventions for DCIS are not generally associated with improvements in breast cancer specific or overall survival because DCIS is a precursor of invasive disease and not in and of itself potentially life-threatening. Thus, recent efforts have been made to not only improve our understanding of the disease and effects of the treatments from a physical perspective, but to understand more critically the psychosocial implications of the diagnosis and treatment of DCIS. To that end, in this issue of JCO, Hart and colleagues provide novel information regarding the experience of women with DCIS. Using serial survey data from a population-based prospective cohort study of women in Wisconsin with DCIS with up to 17 years of follow-up, they analyzed trajectories and predictors of physical and mental quality of life among over 1,600 women after a diagnosis of DCIS and compared them to age-matched controls. They found that physical and mental quality of life was similar to controls based on the SF-36 survey physical and mental health component scores, respectively. However, mental quality of life appeared to be lower for younger women, ages 29 to 49 years at diagnosis of DCIS, in the first 5 years after diagnosis compared with older women in the DCIS cohort, although at later time points this difference was not found. Women who were 10 or more years out from diagnosis had consistently low mental quality of life scores regardless of age of diagnosis, although this was not statistically different from controls. Further, there were no differences in physical or mental quality of life scores observed by treatment type, including use of adjuvant endocrine therapy. Overall, the findings of Hart and colleagues are robust and reassuring with regard to the general physical and mental states over time of women with DCIS. However, the SF-36 provides a broad measure of overall and physical and mental quality of life, but does not evaluate the more nuanced symptoms that women may experience after a diagnosis of DCIS, including common and potentially burdensome side effects of treatment, e.g. chronic pain at the surgical site, as well as psychosocial concerns such as fear of recurrence and anxiety. Previous research has documented that these are major concerns for survivors, and even relatively minor complaints can be quite burdensome for some patients, especially when chronic. Additional medical and psychosocial support may be necessary for some patients to optimize medical and psychosocial outcomes. It should also be noted that women who participate in a prospective cohort study, such as that presented by Hart et al., may be healthier both mentally and physically than women who elect not to volunteer for such research. The finding that mental quality of life was lower among young women compared to older women with DCIS is consistent with the literature in this regard among survivors of invasive breast cancer, although this is the first time it has been highlighted in women with DCIS over time. Young women may need additional supports and intervention given their developmental life stage and associated unique concerns, e.g. fertility, at diagnosis and in early follow-up in particular. Fortunately, there are a growing number of in-person and web-based supportive care programs and resources available that are focused on the needs of young survivors. The research presented by Hart and colleagues expands on the growing literature regarding quality of life of women with DCIS and has implications for both their clinical care and future research directions. At present, based on these data, women can be educated that overall physical and mental health appears similar for women with a history of DCIS compared to controls, with the recognition that they may nevertheless suffer from burdensome symptoms and concerns related to the diagnosis and/or treatment. Future research aimed at understanding in more detail the short and long-term effects of the diagnosis and treatment of women with DCIS is critical to inform patient decision-making, help identify those who may be most susceptible to greater physical symptom and emotional burden for whom supports may be targeted, as well as provide impetus to conduct studies of DCIS management, including evaluating de-escalation of therapy for women with lower risk regions, aiming to optimize not only disease outcomes, but minimize long-term and late effects in survivorship. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.